Dr. Carlo Selmi, and he's going to talk to us about a field that he knows a lot about. It's the division of rheumatology and clinical immunology, where he is the head in Milano, and he continues to be an associate professor at University of California at Davis with Dr. Gershwin. Carlo, please.
Well, good morning, everybody, and thanks to all of you for being here and for this invitation that I had the privilege to receive. It's been a long time since I came to the first BBCers meeting. I think it was about 2002, and I think the organization has grown a lot thanks to Lini, Sandra, and all the people that are actively involved here, and especially thanks to all of you for your active involvement. So, first of all, let me start with a little complaint. I mean, following Eric Gershwin and Chris Bolus and being right before lunch is not exactly what someone would sign up for. I'm joking. I mean, I will try to keep you awake and to win your wait for the lunch, but I will try to keep you entertained and try to show you how PBC doesn't come along in many cases. So we will talk about what in medical terms is called either an overlap syndrome, meaning that two conditions partially overlap, some features of one and the other are actually in conjunction, while others are peculiar to each condition. And we'll also talk about another term that you will hear from doctors now and then, which is comorbidity, when diseases occur together. Let's say diabetes and hypertension are usually coexisting, particularly when people are overweight or in the so-called metabolic syndrome. So let's start with some very basic liver immunology. So what this chart tries to tell you is that on one hand we have the cholangiocyte, which is the cell that lines up on the biliary tree, the pipes that take the bile from the liver all the way to your gut. On the other hand, we have the hepatocyte, which is the brick that makes up the liver parenchyma, the liver tissue. So when the autoimmune attack affects the hepatocytes, we have autoimmune hepatitis. Pretty straightforward. When the immune-mediated attack is directed at the cholangiocyte, we have PBC, and we also have PSC, primary sclerosing cholangitis. And these are different diseases, particularly for the presence of serum anti-mitochondrial antibodies, which you heard the genesis in Eric's talk a few minutes ago. Although there's a little part of patients who do not have serum AMA, although they check it regularly. What we will talk today is this green area here, meaning that patients may manifest characteristics of both of these diseases. So in particular, we will talk about the PBC autoimmune hepatitis overlap syndrome, which is once again takes place in people who have clear PBC and also signs compatible with autoimmune hepatitis, and usually they have a different specific treatment option. This is the outline of what we'll be talking about. So let's start with some general definition. Don't get scared on some of I will just briefly touch some of these issues, so the lecture will still be within the time limits that I was given. Some general definition. And to say it in one word, general definition in here are a mess. So let's say you can have two associated disorders, again, diabetes and hypertension, that can come sequentially, one after the other. They can be diagnosed together. And in most cases, you can't even tell when they actually appeared. So the only starting date you can have is the day in which a doctor told you, you have blood hypertension or you have diabetes. So this is broadly called comorbidity. And we will see, for example, what comorbidities are for PBC. PBC is in about 1/3 of cases also with another autoimmune diseases, and we will talk more about that. It could be just random. I mean, if you have a condition that affects, let's say, 5% of the population, and another one that affects, let's say, 20% of the population, you will have people having both diseases. And this is just random. Doesn't mean that the two diseases are connected. A different field is when you can hypothesize that this is a continuum, that some of the bases of one disease are the same as the others. Once again, metabolic changes related to diabetes, hypertension, and hypercholesterolemia, for example, will have a common ground in being overweight or obese, for example. Once again, overlap syndrome are distinct entities and will warrant different treatment options. And once again, and this comes very nicely from rheumatology, people with one rheumatologic disease may have some features of another disease, especially when connective tissues diseases are involved. And in this case, rheumatologists came up with a genius word for it, and they called it mixed disease. So let's say we have PBC here. The Greeks called the archetype patient. Very nice patient. Middle-aged woman with itching, fatigue, elevated alk phos, positive serum AMA, possibly a compatible liver biopsy if she has one. So that's the prototype of patients. What happens is that this, and I'm sure people in the room can witness this in their own words, these values can change quite a bit. We have our own variability, inter and intra-individual variability, and that's part of the deal here. What if this shows features of other conditions? In that case, we may talk about overlap syndrome. So again, to make things even more complicated is that when people try to study overlap syndromes, as Chris Bolus told us very nicely in the previous talk, they didn't agree on the definition. So basically, if you compare studies in which overlap syndromes were studied, you can't really, mix and match, because in most cases, the definition of a case of overlap syndrome will not be the same across studies. But let's take a step back. We're talking autoimmune diseases. We're talking autoantibodies. I'm sure all of you have received multiple prescriptions for a whole bunch of small acronyms for antibodies, AMA, ANA, SMA. You're all familiar with these words. Let's see how they overlap in the general population. For example, if you take 100 people, there's about 100 of us here, but if you take 100 people out of the street, you will see that about 18 to 20 of them will have serum ANA, anti-nuclear antibodies. Okay? Especially the older they are, the more likely they will have ANA. Does this mean they all have an autoimmune disease? The answer is clearly no. So this is to say that autoantibodies and diseases are not synonymous. But let's say, but ANA are also very specific, very sensitive for autoimmune hepatitis, meaning that patients with autoimmune hepatitis will have ANA, but not all the people having ANA will have autoimmune hepatitis. And of course, you all know that AMA are probably, in the history of medicine, one of the most sensitive and specific tests, meaning that it can identify pretty much nearly all patients while being very specific for having PBC and not other diseases. So if you look in the general population, again, let's say AMA. You take 100 people on the street, how many will have serum AMA? Take a wild guess. Well, it's written here. We did this in about 2,000 people in a northern Italian area, people that were randomly selected in the electorate of the cities. They came, they had their blood drawn, and we checked for liver autoantibodies. And we found that almost 1% of these people had AMA. Does this mean they all had PBC? We're in the process of figuring that out, but probably not at the time of blood sampling. And these are other studies from other parts of the world. You see, for example, China and Japan have been recently very active, and numbers are not very far. So we can say with a good confidence that approximately half a point % of people in the general population will have AMA. What about ANA? I told you about this. This is the very same study, a little more sera. We found that any titer, 180 is a reasonably low titer for ANA, meaning that it could be falsely positive in some cases, while 160 is usually considered a little more positive, if you allow me this word. So let's say about 18% had any titer of ANA, 6% had higher titer of ANA. Meaning, once again, that these people are probably prone to autoimmune diseases now that they have one. What about the two antibodies? In only one case, we found both, AMA and ANA. And once again, as I said, this could be just random sampling results, or it could mean something else, which we will try to unravel as we go. PBC and AIH, autoimmune hepatitis and primary biliary cirrhosis, having features of both. So, as we said at the very beginning, autoimmune hepatitis mostly affects the hepatocytes, so the brick that makes up the liver tissue. And this translates into a more hepatocellular injury pattern in your blood test, which means that more than ACPHOS and gamma GT, what will be elevated is transaminases, AST and ALT. So people having both of these elevated may fall under this type of category. So this is true also for PSC. They can overlap with autoimmune hepatitis. Why do we need to recognize this? Because treatments are different. Ursodeoxycholic works nicely. We heard it from Chris Bolus a second ago. In PBC, doesn't seem to do much, if anything, in autoimmune hepatitis. On the other hand, steroids and other immunosuppressants are very active in autoimmune hepatitis. So recognizes whether one patient has both or either one of these diseases is very important in treatments. How many will have overlap syndrome among PBC patients? We don't know for sure. The figures in the literature said between 2 and 19, which seems a little high to me, % of people with PBC will have an overlap syndrome with autoimmune hepatitis. Usually, we don't know what comes first. People may manifest first features of PBC and then of autoimmune hepatitis, or vice versa. This doesn't seem to make really a big difference. But what's most important is that people who have both, who have an overlap syndrome, seem to have a little more aggressive disease. Once again, justifying the fact that the adequate treatment must be sought. So in 2011, finally, the International Autoimmune Hepatitis Group, to which we all here belong, came out with a position statement on how to define this condition. And what came out was pretty straightforward. On the left, you have the diagnostic criteria for PBC, sure you're all familiar with. You need 2 out of those 3 to be diagnosed with PBC, positive AMA, elevated ACPHOS, and or a liver biopsy showing consistent results, okay? And on the other hand, you have autoimmune hepatitis criteria. And having at least 2 of both of these conditions will allow you to make a diagnosis of autoimmune hepatitis PBC overlap syndrome. Let's go briefly to this. ALT levels at least 5 times the upper limit of normal. This is a pretty high value for any type of elevation of liver function tests. IgG levels must be elevated. You probably know that in PBC it's very common to have the IgM type of immunoglobulins, of antibodies in your serum being elevated. And this usually responds nicely along with ACPHOS to ursodeoxycholic acid. In the case of autoimmune hepatitis, it's more the IgG type. And finally, once again, a liver biopsy that shows mostly a hepatocellular, mostly hepatocytes being injured by the disease. So if you have both these conditions, you may have PBC autoimmune hepatitis overlap, but please bear in mind that there are some type of ANA that are very specific to PBC. And these are usually described as multiple nuclear dots, or MND, as here, or rim-like, in which the nucleus of the cells is colored in a rim-like fashion around it. So what if you have a PBC, let's say you have elevated alk phos, you have a consistent liver biopsy, but you don't have AMA, but you have ANA. What's with that? Cholestatic features, histology of PBC, AMA negative, but you have a PBC specific, one of the two I just showed you, positive ANA. What do you think this is? Is this an overlap syndrome? No. This is a simple variant of PBC, and as such, it should be treated. Okay, so let's not make a confusion out of this, especially since the detection of ANA in the absence of AMA can be better done. So it could be easier to detect an ANA when there's no AMA covering up for it. So same disease course, same treatment as PBC, ursodeoxycholic acid, and no steroids are needed. This is very complicated. This is a very fat slide just to show you that when there is overlap syndrome, immunosuppressants must be used. And so combined therapy, ursodeoxycholic acid and corticosteroids must be used. Corticosteroids can be prednisone, can be budesonide, can be azathioprine, can be cyclosporine. I'm not going to go into details of this, but these are all medications that failed in the treatment of PBC, but appear to be very effective in the case of autoimmune hepatitis. It has to be combined. So although the steroids seem to be the most effective treatment, you still need the ursodeoxycholic acid. So don't do like we do in Europe. You know that the European map can be divided into the Eurosceptics and the Euro-optimists. The people that are very excited about the EU and the people that couldn't care less about the EU. This is pretty much the same for ursodeoxycholic acid. This is a map of Europe that I drew, in which you have neutrals, of course the Swiss. This is not surprising, right? The skeptics, all the Northern European people, all the Eastern European nations, and you have the UDCA optimists. They are very enthusiastic about it, especially France and Italy and Germany and Austria. So just to show you that although there's not a clear indication, especially Europe is not as united as the US, but in terms of ursodeoxycholic, especially the British are very cold, and so we're still looking for some agreement here. Very briefly, no one with PSC here. Let me just tell you that PSC can coexist with autoimmune hepatitis, and this is usually in children. So once again, probably not the age target that I see in front of me right now. What about PSC and PBC? That would be a tough luck, right? You know, having two diseases affecting the very same cell. And to my knowledge, there's only one case that comes from a center close to ours that describes the occurrence of both diseases in the same person. And to me, this is just bad luck. I don't see any connection between the two. So, and this is a lady that was diagnosed first with PBC and then had the liver resection for a benign condition and showed features of PSC both at very early stages. She does not have bacterial cholangitis episodes, not inflammatory bowel disease, so seems to be going quite well in the follow-up. What about other overlap syndrome? So we looked at the liver so far, but we're not just walking livers here. We're people with a whole different type of conditions. Let's move to rheumatology mostly. Let's see what other diseases can coexist with PBC. If you look at the literature, data are horrible. In most cases, there's only case reports, meaning, you know, I say, oh, by the way, I had one patient who had myositis and PBC, and the same with vasculitis. In the case of RA, rheumatoid arthritis, the coexistence is very hard to determine, but we will see data from our own group. The two that appear to be mostly associated are clearly systemic sclerosis, which is a form of scleroderma. We'll talk more about this. And Sjogren's syndrome, a form of Zika syndrome, dry mouth, dry eye syndrome, which has very high figures. Apparently, half of the patients will have either of these. But once again, these are data that I would like to discuss with you a little more based on our data. And I'll take you back about now 10 years. We did this huge, very ambitious study throughout the United States. Enrolled about 1,000 people with PBC. Not surprisingly, most of them were women. From 17 tertiary referral centers throughout the United States. All states from the United States were represented except for Hawaii and Delaware. Don't ask me why, probably because there's too few people there. But all other states were represented with more or less the blue states are the ones, there's nothing political there. The blue states are the ones that gave the most patients. And then we did something called random digit dialing to find the same number of controls. How does random digit dialing work? I'll tell you this because it's like a very interesting thing. So for each patient with PBC that accepted to take part of the study, they took the phone number and they took off the last 4 digits of their phone number and start mixing and matching these numbers and calling the numbers until someone with the same sex, same ethnic group, plus minus 5 years, who did not have PBC and was willing to answer some questions, answered the phone. So this led to about 80,000 phone calls, okay, to identify about 1,000 people with the same sex, same ethnic group, of course coming from the same area because the phone number was largely the same, and did not have PBC. And so we started asking them about 300 questions, okay, about their health, their risk factors, their family history. Was very long. I can tell you that some of these people, probably not the brightest in the bunch, took about 18 hours to answer in more than a phone call. I mean, they didn't go like all the way, but it took them 18 hours. Most cases was about 2 or 3 hours. So what came out of this about comorbidity is that, let's start, I'm sorry, I hope you can see this. First of all, autoimmune thyroid disease. Someone was asking about it. Please keep in mind that these are all self-referred diagnoses, meaning people were asking patients, do you have autoimmune thyroiditis? They said yes or no. So they were not proven by any physician or medical record evaluation. So 9% of people with PBC had autoimmune thyroid disease, which is pretty high, compared to 1% among controls. Okay? Again, whether this reflects, I think this reflects the coexistence of autoimmunity, this so-called kaleidoscope of autoimmunity, the fact that autoimmune diseases often coexist with each other. Let's dig a little deeper. Raynaud's syndrome. Do you know what Raynaud's phenomenon is? Who said yes probably doesn't live like in Florida or California because it has to be a little cooler than that to experience it. Raynaud's syndrome is what, oh, sorry, I don't think you can see it here, but it's when basically related to the cold weather, cold temperature, or to an intense stress. You get really mad at someone when driving or with your husband or something. Your finger, both of your hand or your feet, start getting white. And then they become blue, and then they become red. There was a time in the history of this country in which this resembled a little too much the French flag, so they wouldn't admit to it. But this is what Raynaud's phenomenon is. It could be what we call idiopathic, which is a very nice word to say we have no idea where it comes from. So when you hear someone say, "Oh, it's idiopathic," it's just a way to say, "I can't even imagine. I can't even imagine where this comes from." But in PBC, it does seem to exist more often than in controls. 12% of people with PBC had Raynaud's phenomenon versus 2% of controls. So once again, this could imply a significant association or just be a mere association. What do you do if you have Raynaud's phenomenon? Usually you do a blood test, you do antibodies, but on the other hand, the main test would be nail fold video capillaroscopy. So first of all, let me tell you that you should not have a manicure within 4 weeks before doing this test. Otherwise, there's no nail fold to look at. But what to do is somehow like an ultrasound of your fingernails, and we show the capillaries in your nail fold, and we'll be able to tell if they're big, if they're small, if they're lacking, and this will be able to detect whether the Raynaud's phenomenon is something completely benign that you have to live with for your entire life, perhaps wearing gloves, or avoiding doing the dishes with cold water, that kind of thing, or if you need to go further and find a treatment for this. Sjogren's syndrome. Chris mentioned it about the hard candy in his patient. 10% of people with PBC will have a Sjogren's syndrome diagnosis versus half a point percent in controls. What is Sjogren's syndrome? Mostly Zika syndrome. Zika syndrome means dry eyes. The way people tell it's usually like having gravel in their eyes the whole time. Dry mouth, and getting married or stuff like that doesn't count for a dry mouth. I mean, you have to be in your regular life and just feeling the urge to drink the whole time and to wash your mouth the whole time. But there's a whole list of symptoms that may come with it. And I'm sorry, and for women, this may also cause vaginal dryness. But other symptoms include arthralgias, joint pain, or actually an arthritis. So a joint pain, it also includes swelling and pain, especially at resting, with stiffness in the morning. Raynaud's phenomenon, we talked about this, gastrointestinal syndrome, a whole bunch of expressions that may lead to a Sjogren's syndrome suspicion. What's interesting between PBC and Sjogren's syndrome is that they seem to be cousin disease, meaning that in some cases, the pathogenesis, which is why the disease ensues, actually are very similar. Of course, one affects the biliary epithelium, and the other one, the gland epithelium, salivary gland, and the lacrimal gland, but still the mechanism might be common between the two. Scleroderma. We talked about this a second ago. Scleroderma is not a synonymous of systemic sclerosis. Systemic sclerosis usually affects the whole body. It's a systemic disease, so it will also include internal organs with their affection. 2% among cases, 0% among controls. How this relates to the real disease, it's pretty good, because this is a very rare disease. You see, the prevalence is about 50 cases per million, which is, again, very, very rare. Unfortunately, women outnumber men also in this case by quite a lot. And it can be localized. It's usually called morphea, or linear, which is sort of a line here of tough skin and usually has no clinical meaning, or systemic, which could be diffuse or limited depending on whether this type of affection, I don't know if you can see sclerodactyly, which means hardening, thickening of the skin, starts from the tip of your fingers and can go all the way to your elbows. If it goes beyond your elbows, it will be diffuse, otherwise it would be limited. But this is something that clearly can be recognized by any rheumatologist, and I'm sure it will also raise your suspicion once you see it. Same disease can also cause deposits of calcium, which you see here in an X-ray, especially at the tip of your fingers. But once again, this can ulcerate and be painful. But once again, these are things that are hard to miss, and as you see, have been found in a minority of patients with PBC. What about family members? We talked about this before briefly. We know PBC does have a family risk, but I do agree with Chris and Eric, there's no point in screening your family members unless you have a reason to think of it. Unless they have an elevated alk phos, unless you have other reasons to check for PBC in your relatives. But PBC is indeed more frequent in the relatives of patients. About 6% of patients will have another member of their family being affected by PBC, versus 1% of the controls. Who are they most likely to be? Sisters, mothers, and daughters. Again, not surprising. Women, first-generation relatives. Unfortunately, this type of clustering in the family is true also for other autoimmune diseases, particularly thyroid disease and Sjogren's syndrome. By not a lot, but once again, if you have a PBC case in your family, your relatives are a little more likely to develop other autoimmune diseases, including thyroid disease and Sjogren's syndrome. What about other comorbidities? Let's move out of the autoimmune field for a second and talk about fatty liver. Do you know what fatty liver is? Have you ever had foie gras? Okay, now it's illegal to make it. But, well, in France it's not illegal. Nothing is illegal in France. But anyway, they fed the ducks with bread. They forced ducks to eat bread until their livers became very fat, very, very fat, and then they processed it and made the pâté, the foie gras, okay? And I'm not telling anybody that you're ducks or anything like that, but the process is the very same. Our liver gets fat the way we get fat. We gain weight, our liver gains weight. And so we have what's called non-alcoholic fatty liver. What's non-alcoholic? We'll see that in a second. It means that we are taking alcohol in a much less amount than what's advised by the World Health Organization. Is this scary? I would say not really, unless you have other reasons to worry. Hypertension, diabetes, obesity, that's a whole different issue, okay? When do you have to worry? When NAFLD, non-alcoholic fatty liver disease, becomes NASH. NASH is non-alcoholic steatohepatitis, meaning that there's an inflammatory component to it. And this can progress. And of course, as you may imagine, if NASH coexists with PBC, their damages can be multiplied by a factor. What is NAFLD? Non-alcoholic. What is the cutoff? 20 grams of alcohol in women, 30 grams a day in men. How do you calculate this? I left this in Italian on purpose because, we have one or two things to say about alcohol. A beer, a regular beer, equals a glass of wine, equals an aperitif, equals a little shot of tequila or whatever. I know they have different alcohol contents, but if you want to make a rule of thumb type of calculation, each of these adds up to about 12 grams. So if you want to say how much a person drinks, you ask, so how many glasses of wine you have in a day, how many beers, and you just sum it up, multiply by 12. If it's more than 20 in a woman, that's an alcohol abuse. If it's more than 30 in a man, that's an alcohol abuse. So literally for a woman, 2 drinks in a day are an abuse. Why women and men are different? I would rather ask this question to all the men in the room who I think are, we all had some sort of social fortune because of this, but what's the point is that if you're below this threshold for both sexes and you develop a fatty liver, you will have a non-alcoholic fatty liver disease. What is NASH? NASH is when you have hepatitis. The point is that the only way to dissect between the two is to do a liver biopsy. There's nothing that can tell you right now if you have a NASH or a NAFL. Why am I telling you this? Because when people with PBC have NASH, they do much worse. So what does this translate into? Remain fit, eat healthy, and don't drink. Pretty straightforward. So try to avoid the risk factor for developing NASH. Let me just finish up by something that I hope won't scare some of you. We might be overlooking one factor in the case of PBC. Can anybody guess what it is? Environment. Very good answer. I'm going to need be a little more specific than that.
Diet.
Diet. Yeah, I'm talking about something that encompasses all of this. And it's sitting in your purse or in your wallet. It's not euros, but it's money. Why am I saying you this? Let me take a step back. In the United States, to do liver transplantations, you need to be part of what's called UNOS, United States National Organ Sharing System. So for each liver transplant you perform, for each person you put on a waiting list for a liver transplant, you need to put in their data in a database. Okay? Let me tell you another thing. In the United States, every 2 or 3 years, the Ministry of Treasury does something called a census, meaning that it will take about 2 or 3% of the population and find out how much money they're making and a whole lot of different information about them. So let's say you have a snapshot of the U.S. society as we progress with the years. So what we did was to take all the people that underwent a liver transplant in the United States for different conditions, okay, and estimate their income. Thanks to the census, if you know the age, sex, scholarity, zip code of a person, plus or minus 20%, you can tell exactly how much he makes. It's scary, I know, but it's what it is economically speaking. So we applied this to all the people taking a liver transplant in the United States over the past years, okay? And this is what came up. That we have a letter. Primary sclerosing cholangitis are the wealthiest. People with autoimmune liver disease undergoing a liver transplant are making way less than any other people undergoing liver transplant in the United States, including alcoholic liver disease, which you may suspect, may be associated with some poor background or something. So this is something to think about. I think it has two meanings. The first one is probably that this translates, the higher your social ranking is, you probably get a slightly better care, so you get diagnosed with PBC earlier. That's one possible explanation. The second possible explanation is related to the first one, and is that probably undergoing liver transplant is the result of different parts of bad luck, including a late diagnosis or an appropriate treatment. So this is all to say, I'm not saying that money causes any of these conditions. Okay, don't give away your money, or except to the PBCers, of course. But that's not the point I'm trying to make. But I'm saying that once again, autoimmune diseases are down there at the bottom of this letter. So, in conclusion, I'm going to wrap it up. There's more questions than full stops there. You see this. What we see, are they random combinations of different diseases? Do they different manifestations of the same disease process? This would be fantastic. You would then need just one bullet to fix them all, which is not the case yet. Could it be like the kaleidoscope of autoimmunity? You look into this, you may see thyroid, you may see scleroderma, you may see PBC, you may see all of them together. Keep in mind that one answer may not fit all, and I think the genetic studies to which Eric and Chris were referring to are very good at answering this, because except for some genes that seem to be barely associated with more than one condition, the genetic bases seem to be very different. And for example, if you take monozygotic twins that share the very same DNA sequence, very same, and grow up usually for about 12, 14, 16, 18 years in the very same environment, okay? And one of them develops PBC, only in 6 out of 10 pairs, the other one will also have PBC. If you take rheumatoid arthritis, it's even lower. It's about 30%, meaning that 7 out of 10 pairs of monozygotic twins will only have one case of rheumatoid arthritis. If you take systemic sclerosis, it would be 5%. So very, very, very thin genetic background, or at least not sufficient. Probably necessary, but not sufficient. Recognition is crucial, because we need to get better customized treatment. Chris was answering a $1 million question before as to why some people respond to UDCA and others don't. And we have no idea about this yet. And finding that answer will save you some time and probably all taxpayers some money. Raise awareness of possible association to achieve timely treatments. So tell your doctor if you're feeling different symptoms. I gave you a glimpse, but some conditions are much rarer. For example, we found systemic lupus erythematosus in a tiny slice of patients with PBC, more likely than in people without PBC. But and lupus is probably the disease that can affect any tissue, any organ you can think of. The nervous system, the joints, anything you can think of, the kidney. So any symptoms that may come to mind, that may occur to you, please share it with your doctor. So in conclusion, allow me to thank the people. This is the group I have the privilege to work with in Milan. And I'm very sorry that Eric left, because I wanted to show you this old picture in which Eric was playing a song and I was singing. And of course, being Italian, I was singing That's Amore, which is something in between the two nationalities. So thank you very much for your attention. All right. Since women make less money and more women have PBC, couldn't that explain lower income? The answer is you're absolutely right in the fact that the bottom of the ladder was made by two diseases that are mostly women diseases. But the fact is that we did correct for that, and that didn't show any importance there. Sorry, no way to struggle for that.
That's related.
Why does PBC prefer women? Oh, I wish I knew that. Well, the good news is that this applies to basically all autoimmune diseases, with very few exceptions. Type 1 diabetes, inflammatory bowel disease, if you call that an autoimmune disease, psoriasis, except for these, they're all female predominant diseases. Why does this happen? There doesn't seem to be a correlation with sex hormones, meaning reproductive life. They've tried all of this, having had more or less pregnancies. We also did a study on nuns, as you know, but we couldn't find any factor there that explained this. So my answer is I don't know. I really don't, but I wish we knew. I know we behave differently in front of women. Let me tell you something which may be a little curious. Cardiologists, when they have in front of them a woman or a man complaining of symptoms that may relate to coronary heart disease, a heart attack, okay? They tend to ask less questions and to ask for less tests if the symptoms are complained by a woman. But that's because they think in their mind that, you know, coronary heart disease is more frequent in men. So one of the perhaps audacious ideas I have is that perhaps we see PBC less in men because we're looking for it a little less. We're suspecting it a little less in men. But that's, out on a limb. Do drugs that have been approved in Europe have to go through the complete FDA protocol? Unfortunately, yes. The data can be the same, but especially recently, we experienced some very conflicting views by the two authorities, the EMA in Europe and the FDA in the United States. For example, for one oral drug for rheumatoid arthritis that was approved now 2 years ago in the United States, which is tofacitinib, has not been approved in Europe yet due to safety concerns. So the answer is absolutely yes. And I think this is a good news, unfortunately. I think this increases the safety of the process. I know some of you may disagree, but I think this increases the safety of the whole process. Compare XChem Urso with generic version. Is Urso worth the cost and benefits? Is one generic brand better than another? Urso worth the cost and benefits? Absolutely yes. I have no doubt about this. And I think both John Vierling and Keith Linder, which I see entered the room, I think will agree with me on this. About generic brands, I have no preference whatsoever. Absolutely. We have one peculiarity in Europe, that we have some retard release system or so, and that's completely to be avoided because it doesn't have any data supporting it. It's a one a day, but it's not even a problem here. Oops. What percentage of those affected with autoimmune hepatitis also have PBC? Very few, very few. Actually, the data show that if AMA are found in people with autoimmune hepatitis, and these people are observed for at least 10 years, very few of them will develop PBC. And whether this is a result of the fact that they take immunosuppressants or the fact that, again, they're two different diseases, I can't tell you. But the answer is very few. What is the prognosis of women or someone with PBC autoimmune hepatitis and multiple other autoimmune diseases? Almost 20 total. One huge autoimmunity problem. As far as these autoimmune comorbidities don't preclude the treatments, I don't see any reason why they should interact. We have one good example, which comes from from women who have PBC and scleroderma. Their PBC seems to do much better. And this is also true for other rheumatological conditions. So apparently, when two diseases coexist, they could be a little more benign, less aggressive. For example, in PSC, primary sclerosing cholangitis, IBD, inflammatory bowel disease, which is found in a large group of patients, will be a little milder than IBD in those who do not have PSC. So this is, unfortunately, the only answer. 20, considering that there's about 80 to 100 autoimmune diseases today, 20 is a pretty good number. Oops. Can ANA markers disappear? Years ago I had it in the thousands. Now it isn't there, but AMA showed up. Is it possible for one disease to morph into another? ANA can sometimes disappear. In the case of lupus, this is usually the effect of treatment. In the case of PBC, they're pretty stable. Especially the PBC-specific ones we saw, they're usually very stable over time. We observed them for about 6 to 8 years, and they seem to be, only in a few cases, they appeared or disappeared out of nothing. So it's whether a disease can morph into one another, very unlikely, I would say. Probably it was sort of a soft diagnosis to begin with, or it was manifesting in a peculiar way. On the economic factors ladder, what percentage of the number of transplants does each disease represent? Oh, I can tell you that. Can I have the slides again real quick? Thank you. Yeah, please. Oh, okay, from start, let me just be rather quick. We're in the thousands anyway, but where do we have to point? Oh, there. Almost there. There you go. So the total is 51,000 transplants between 1989 and 2010. And of course, all the incomes were compared to the year 2000 in terms of purchase power. These are the crude numbers you were probably looking for. See, for PBC, over 2,000 people. What criteria are you basing someone responding or not responding to? Or so, well, what Chris mentioned is probably the best guess today. 1.67 times the upper limit of normal is probably the best guess we have right now. And because it seems to make a difference in terms of survival and progression of disease. I have been on Urso since December 13. Does the gastric distress ever resolve? I have the complication of having a vertebral gastric sleeve. Usually side effects do get a little better. As Chris was saying, you might be willing to try to move your schedule a little bit around meals, because that may it does change somehow the absorption too, but not significantly, and so you might want to play around with it. And perhaps some prokinetics, meaning the drugs that will allow you to empty your stomach faster, if this is not only an ulcer-related symptom, may be beneficial in your case. Is constipation, bloating, and irritable bowel syndrome related to PBC? My answer will have to be no. These are very non-specific symptoms, very frequent in the general population, and perhaps they could be related to the fact that you get diagnosed with a chronic disease affecting the digestive system. You're a little more likely to refer these, but my answer will have to be no. Does having PBC affect the digestive process, resulting in severe unpredictable loose bowels as a result of no. My answer would be no. Steatorrhea, meaning fatty stools, that they're hard to be, sorry, we're before lunch, to be cleaned from toilet. That's being referred as one symptom, but honestly, I don't believe we should base our decision on that. There was a European study, I believe, that agreed PBC is more muscles fatigue. Do you know anything about this? There's one group in the United Kingdom that showed different physical basis for the fatigue in PBC. And apparently fatigue in PBC is not as much the lack of capacity to perform an effort as in the stamina, in the endurance of the effort. Meaning that you can carry your grocery home for a certain amount of time, and then you have to drop it for a little bit. That's something that we did see also in our group, in some people with PBC, as a central reflex. Meaning that it was our brain that told the muscles, you're tired, before they were actually exhausted. I don't know if I'm making myself clear. What usually happens is that if you carry something heavy, okay, if you carry something heavy, at a certain point your muscles would say, I can't take any longer, tell it to your brain would say, just drop it, okay? And you would drop it. In the case of PBC, it seems like there's a derangement between these two mechanisms, as if your muscles are not really exhausted, but your brain is convinced that they are, okay? Whether this translates into something that can be therapeutically approached or not, way too soon to tell. Can treatment reverse cirrhosis so transplant is not needed? Ooh, this is a very tough question. Cirrhosis is a reversible process, okay? It's no longer considered irreversible. But if you ask me whether ursodeoxycholic can reverse cirrhosis, I'd say, to the best of my knowledge, I don't think we can say anything like that. So, but there's lots. The good news is that fibrosis and cirrhosis are the common ending of all chronic liver diseases. So any treatment that may come up for alcoholic cirrhosis or hepatitis C cirrhosis will most likely be beneficial also for PBC-related cirrhosis. So, what is the definition of non-responders to urso? We said that. That's the best guess I can come up with. No, I already took this. Yep.
Okay.
Okay. If liver enzymes, all but the ALK-Phos, is in normal range, is it important to try to get the ALK-Phos down into range? ALK-Phos had already been in the range of 110, 180 since 314, 229, 240. My answer is that you need to look at the broader picture, because ALK-Phos does not just come from the liver and from PBC. It could, for example, ALK-Phos can be elevated if you gain weight, Okay, it could be a sign of a fatty liver, and it's impossible to dissect which comes from which. Or it could also come from fast weight loss. I know it's sort of a paradox, but that's one reason. It can also come from the bone. So if you see this before counting urso out and say, okay, it's got to be the urso stopped working, trying to consider other ways as well. What is the difference between ALK-Phos and gamma-GT? Ooh, which is more important? This is a very tough question. I would say gamma-GT is probably a little more sensitive, meaning that it will be positive if you have cholestasis, okay? But on the other hand, alkaline phosphatase could be a little more specific, meaning that it will be elevated if you have cholestasis. I don't know if I'm making myself clear here, but let's say gamma-GT can be elevated, for example, if you drink too much, okay, or in the case of a fatty liver. While on the other hand, ALK-Phos is a little more specific for having a real cholestasis, meaning a real trouble in the efflux of bile. Okay? Tough one. Whoever did this is tough.
Very good.
All right?
Carlo, thank you very much.
Thank you. Thank you very much.
Before you leave, I got some hardware I got to give you. On behalf of the PBCers, I want to thank you for a very entertaining and very informative presentation to us today, and good luck in Milano, and don't be a stranger. Come back and see us.
I will, absolutely will.
Okay.
Thanks, Bob.
You bet.
Thank you very much.